reason why this is particularly important to know whether the patient has an associated heart block is because if a patient has got a second-degree type 2 heart block or a third-degree heart block, it's indication for permanent pacemaker. Because there's a good chance of a second-degree heart block progressing to a third-degree heart block. And potentially, or rather, it's likely that a patient can become hemodynamically compromised and potentially can get low cardiac output, resulting in potential death. That's why it's an important consideration. If a patient has a lower degree heart block, such as a second degree type 1 heart block, but they are symptomatic together with the second degree type 1, it's also potentially a consideration for a permanent pacemaker. Now, an additional gem here to consider would be ventricular bigeminy. I don't have a rhythm strip here for review, unfortunately, as I thought of it on the spot, but rather, ventricular bigeminy simply reflects premature ventricular complexes, otherwise known as PVCs, that happen in a regular pattern with normal P and QRS complexes. So it would look like this. And you get a ventricular complex, and you get a normal PQRS, and you get a ventricular complex as well. So this is paired, and that's why it's called bigeminy. The reason why I pointed out ventricular bigeminy in particular is because often someone with ventricular bigeminy would have half the pulse rate or potentially have half the pulse rate than their actual ventricular rate. So let's say, for example, if a patient with ventricular bigeminy has a ventricular rate of 80 beats per minute, or rather they have 40 times each of these sets. So 40 multiplied by this will give you a ventricular rate of 80 beats per minute with one normal QRS complex and one premature ventricular complex in a set, just to be clear about that. The issue is that the premature ventricular complex, which happens in bigeminy, because it happens so frequently, there's often insufficient time for the ventricles to be adequately filled. Therefore, during the ventricular contraction that happens with a PVC in a bigeminy, there may be insufficient cardiac output to be detected on clinical examination by yourself or the nursing staff in the peripheries or by a machine. And therefore, the heart rate that we recorded will only be the normal QRS complex, which I'm highlighting in yellow. But the ventricular complex that's premature in purple will not be recorded potentially. Therefore, someone with a ventricular rate of 80 beats per minute with bigeminy could have a quote-quote heart rate of 40. But you're reassured if the rhythm shows ventricular bigeminy, as the patient would not be likely to be compromised, as it's often a benign rhythm. Now, let's move on. It's important at this stage to now consider the easily reversible causes. And this includes thyroid abnormalities and electrolytes, including potassium and calcium magnesium phosphate, whereby potassium is often part of a urine electrolytes panel, but you have to order the calcium magnesium phosphate separately, as well as the life-threatening causes. And that would often be something like an AMI. Of course, the ECG would be pretty obvious should there be ischemic changes, including T-wave inversion, ST elevation, or ST depression, and the patient would potentially be symptomatic as well with chest pain. So, if the patient doesn't have blood sent off for these things, it may be good to do so at this point. Send off some thyroid, send off some calcium phosphate, send off a urine electrolytes panel, and potentially consider troponins if the patient has got some chest pain or ECG signs of changes. Another consideration would be to do an FBE anyway, as anemia can also contribute to hemodynamic compromise because your blood that's being pumped around may not be carrying sufficient oxygen. Should the bradycardia, coupled with the bradycardia, that could be bad. Now, in terms of treatment, aside from treating the thyroid dysfunction and replacing electrolytes, if the patient is hemodynamically compromised, you can consider pharmacological treatment for the bradycardia specifically. If they're asymptomatic, once again, it's potentially reasonable to not treat them. So if they're hemodynamically compromised or if they're symptomatic, atropine is a drug of choice, as I mentioned. And atropine is a muscarinic antagonist. So essentially, it's going to block the cholinergic system from the vagal. It's going to block the cholinergic system. It's going to block the vagal tone to the heart, increasing AV conduction. Now, you may be wondering, why do we not use an inotrope or a chronotrope, such as adrenaline? In this circumstance, using adrenaline can potentially be dangerous because it can potentially precipitate a ventricular tachyarrhythmia. So that's generally not considered, and it should not be something a junior doctor shouldn't be considering using that as a drug of choice. Now, with atropine, a simple trick to remember is that you can often give 0.5 milligrams 5 minutes apart, and you can give up to 2.5 milligrams. It's easily remembered as 0.5 multiplied by 5. It's going to be 2.5. Anyway, it's just a silly way, but a simple way to remember things. Further things to consider at this stage would be to consider to put the patient to a cardiac monitoring bit. In other words, telemetry, as you want to make sure that the patient does not develop a more serious heart block, potentially, or you want to see how high is the burden of heart block, as a patient may potentially be going in and out of heart block. Or if the patient is in sinus bradycardia, you want to see whether there's a rhythm abnormality, such as a heart block, that the patient comes in and out of. Anyway, there are many indications for telemetry, which we will not be going into, but those are just some broad underlying principles. If atropine is ineffective, you can consider transcutaneous pacing. That's just like putting a defibrillator pad on the patient. Well, not really, but you're putting pads on the patient and delivering shock to cause ventricular contraction, just like an implanted pacemaker, except that's external and from the skin and can quickly be applied on. Now, it might be great to consider advice from your cardiology colleagues if you're in the internal medicine unit, or to seek advice from your cardiologist should you be in the cardiology unit. Anyhow, that brings us to the end of this video. If you like it, once again, please consider giving a thumbs up or to subscribe to the channel. Any feedback, good or bad, please feel free to leave them in the comments. Thank you so much again for your time.